I would like to thank Dr. Sudipto and the organizing committee, Indian Pancreas Club, for giving me this opportunity. So the talk is on branch duct IPMN, re-evaluating the existing guidelines. So I'll take you through a comparison of various guidelines and touch upon the recent Kyoto guidelines and maybe briefly give some overview about the unmet needs, gaps and future. So Sendai guidelines published in 2006 was the first guideline to type the IPMN as well as define the high risk lesions of more than 3 cm of cyst size to go for surgery and rest all to be undergoing surveillance. Later on, a lot of these guidelines have come up in 2012, 2015, almost 3 times. The IAP has come up with the revisions, AGA one time, ACR one time, ACG one time, European guidelines, and Hong Kong also has group was also published 2 years ago. So a multidisciplinary team has come up and formulated the European, ACR and the Fukuoka guidelines each time, but the medical gastroenterologist has come together to formulate the American guidelines. So if you see the overall guidelines, European guidelines were the most generalized. ACG has included the pancreatic cysts, but they have actually excluded the those with genetic predisposition. Fukuoka guidelines have specifically emphasized on IPMN. AGA has touched upon only the asymptomatic cysts and have excluded all the high risk lesions including main duct IPMN. ACR guidelines also pertain to all incidental cysts. So if you see the classically described high risk features and worrisome features across all the guidelines, symptoms or imaging or some serum based biomarkers were used. Jaundice was the uniform criteria of absolute or high risk event. Pancreatitis was a relative event. And if you see these high risk features or worrisome features, European guidelines advocate straight surgery, IAP advocates straight surgery. ACG actually asks us to put into MDT forum and then decide about EUS FNA. AGA actually advocates EUS FNA. Coming to the imaging guidelines, more than 10 mm is absolute indication, more than 5 mm is actually a relative. Associated mass is a high risk feature, mural nodule more than 5 mm is a high risk feature, less than 5 mm is a worrisome feature. Cyst size of 3 cm or 4 cm is actually a high risk feature. Associated pancreatic ductal stricture, parenchymal atrophy are worrisome features. Associated lymphadenopathy is a worrisome feature. High CA19-9 is a high risk feature, and also new onset diabetes is a high risk feature, especially in European guidelines. IAP has actually put forward that if there is more than 5 mm growth on surveillance in 2 years, that's a high risk feature. The primary imaging modalities were either MR, CT or EUS plus minus FNA in all these guidelines, except AGA where it has actually excluded CT in its imaging modality. So once the cyst, as per the size, we classically actually go for these kind of things depending on the cyst size, 1 cm, 1 to 2, 2 to 3 or 3 cm. Generally, if the cyst is more than 3 cm, we opt for MR or EUS every 3 to 6 months. If it is around 1 cm, the surveillance interval is between 2 to 3 years. But if it is between 1 to 3 centimeters, it can be anywhere between 3 months or 6 months or 1 year, depending on the guideline. What about stable cysts? How long do you actually survey these patients? AGA says that you can stop at 5 years. ACR says that you can stop at 10 years. And for European guidelines, ACG guidelines and the IAP guidelines, you need to survey them for life. What about after surgery? All the malignancies that adenocarcinoma, you need to follow the guidelines. If there are dysplasia, generally in European IAP and ACG, they say that you need to survey them for every 6 months, and AGA says that every 2 years. Obviously, it is guided by depending on the risk factors. How does these various guidelines perform? Studies have shown that AGA and IAP has higher diagnostic accuracy than Sendai guidelines. AGA has higher specificity but lower sensitivity than IAP. Ma et al. Showed that both perform similarly. AGA guidelines have actually been shown by Singhi et al. That it has low accuracy and it need to continue with the continued surveillance even in benign lesions. A few studies have shown that AGA could miss significantly more high-grade dysplasia and carcinoma. So we need to have better biomarkers, both diagnostic and prognostic. We need to have composite scoring systems and histological criteria. And current guidelines have increased our focus on high-risk lesions and lessened the surveillance intensity for the lower-risk lesions. And none of these guidelines have actually sufficiently, they are accurate to define the actual diagnostic strategy. Then comes this latest guidelines last year in 2024, again revised IAP guidelines known as Kyoto guidelines published in pancreatology. It basically focused on revision of the existing high-risk stigmata, worrisome features, surveillance intervals, pathology updates, and also molecular markers based on extensive evidence based on systematic reviews. The new algorithm actually integrates this EUS and contrast EUS findings and cytology for assessment of high-risk features and worrisome features, and also the surveillance options say that you can continue or stop at the end of 5 years when the small lesions are stable. So the pathological lesions are classified as low grade, high grade, or carcinoma in situ or invasive carcinoma. All these terms of malignancy is discouraged. If possible, better to subtype them because they can add to the discriminant information, whether they are gastric type or intestinal type or pancreaticobiliary type, especially after surgical specimens. It is clearly defined defined entity, that is oncocytic neoplasm. If possible, genetic alterations can be actually studied. It helps in differential diagnosis of other PCLs. The KRAS and GNAS mutations are very common in these lesions, and we can identify the progressive lesions, at risk lesions, by studying TP53, SMAD4 and CDKN4 2A. Low grade dysplasia doesn't mean that they are not at risk, still they need to be under surveillance, and high grade dysplasia and invasive cancers need to be separately reported. And we need to measure and report the size of invasive component, but of course T staging and reporting can be challenging. So after physical examination, a series of laboratory tests are run on these patients: CEA, CA19-9, the sugar profile, and the cross-sectional imaging. With all these modalities, we can achieve to a diagnosis of IPN in up to 80% of cases, and high-grade dysplasia or invasive cancer in between 75 to 97% of cases. Add contrast and EUS, it is useful for mural nodules and solid component evaluation. If you start aspirating the cyst fluid, you can get a cytology which is sensitive in 28% and can study various markers like mucin, CEA, DNA mutation, and glucose. Of course, there is a negligible risk of peritoneal seeding, and PET scan and the role of ERCP is still limited. If you see various markers, the famous and most cheaper available in our country, that is glucose less than 50. It is the most sensitive and specific marker. CEA, which is most commonly used, has a higher specificity of 87%. Mutation analysis like KRAS, GNAS are sensitive in 79% and specific up to 98%. Other molecular markers, genetic mutations, they are more specific up to 90 to 98%. CA19-9 in the serum is more than 37 is a good marker to detect invasive cancers. So if you see the algorithm put forward by this group, you first assess the high risk stigmata using MR or MDCT, and if there is a high grade dysplasia or invasive cancer suspected, you can add EUS. So any patients with obstructive jaundice, a mural nodule more than 5 mm, main pancreatic duct more than 10 mm, or a positive cytology, then consider surgery. If it is not there, then think of other worrisome features. If the patient is having acute pancreatitis, elevated CA19-9, is there a diabetes, cyst more than 3 cm, enhancing nodule, a thick enhancing cyst wall, main pancreatic duct between 5 to 10, abrupt change in the caliber, lymphadenopathy, cyst growth more than 2.5 per year. If there are there, then think whether there is any recurrent acute pancreatitis, multiple worrisome features, and is the patient is fit for surgery. If that is not there, then depending on the cyst size, what is the largest cyst size if it is a multifocal lesion? If it is less than 2 cm, do imaging at 6 months and then at 1.5 years, or do imaging twice if it is 2 to 3 centimeters at 6 month interval and then every year, and if it is more than 30 mm, it is every 6 months. And then you can choose if they are not progressing to continue surveillance or stop surveillance, depending on various factors like regional economics, risk of concomitant ductal adenocarcinoma, age, comorbidities, life expectancy, patient preference, etc. So what about after recurrence? There is a risk of 10% recurrence in the remnant pancreas at 5 years, especially those who had high-grade dysplasia in initial specimen with a family history. It can be because of new multifocal IPMN or a recurrence or a concomitant PDAC. The generally recommended thing is if there is a high grade dysplasia, it is at 6 months, or if there is no risk factor, it is at 1 year. So what about multifocal lesions? It can happen in 20 to 40%, usually independent lesions. It does not increase the risk of high grade dysplasia, but you need to manage the highest risk lesion, but avoid prophylactic total pancreatectomy in these cases. What about adjuvant therapy? Generally no role unless there is adenocarcinoma. Ablations, especially you can give an option in non-surgical patients, unilocular mucinous cysts. It has some efficacy in 70% with some adverse events, and it is restricted to clinical trials. So coming to the gaps, we need prospective validation of growth and feature-based algorithms. We need unified risk-adapted surveillance strategies. We need to standardize the EUS criteria and especially the contrast EUS for nodules, enhancement patterns, etc. Who is going to directly go for biopsy or surgery? We need better biomarkers to predict invasion and high-grade dysplasia beyond KRAS and GNAS. Concomitant PDAC and risk stratification is needed, and post-op pathways that need to be calibrated as per the margin positivity or negativity is needed. So to summarize, branch duct IPMNs are crossroads at night. Each guideline a lantern casting its light. Sendai shown first, size was its guide, but many were cut, though danger denied. Fukuoka refined with features to weigh, nodules and ducts to show us the way. Europe split the paths, absolute and relative science, while AGA urged caution, drawing firm lines. ACJ spoke of growth, subtle but real. Kyoto brought the balance, a stop or continue to seal. Together they teach us, though none stand alone, surveillance the compass to which we have grown. For in this long journey through the shadows and doubt, wisdom is knowing which lights to snuff out. Thank you so much for your kind attention.
Thank you. Chalapathi, you made this poem or is available in that?
With assistance of internet.
Anyway, wonderful talk. And suppose there is a person who has got less than 2 centimeter and is young. What will you advise him? How long need to go for screening?
As of now, even in stable lesions in 2 centimeters, generally we actually do it between 6 months to 1 year, maybe for a couple of years, and then we can choose to talk to the patient if there are no other risk factors like ductal adenocarcinomas, no genetic mutations. Probably we can stop at 5 years.
In elderly person, I agree that you can stop at some point of time. Young person, what will you say? That's the challenge. You can ask for questions.
No, that's a great talk. So one of the problems with all the guidelines is when you're doing EUS, say, in a cyst between 2 and 3 centimeters or greater than 3 centimeters, 6 monthly, annually, assuming you will take a sample, and sometimes you get a CEA that's up, then it's down, glucose is up, glucose is down. Are you routinely doing, KRAS testing or molecular testing on these samples, or what would you do with that result? If it's going up, are you thinking about, is it transforming? Are you thinking about surgery at that time, or would you just wait another 6 months and then do it again? So I think that's a problem with with the current set of biomarkers we have.
Right. So always that's the gray zone, as Matthew sir has pointed out, you have pointed out. We are currently pulling some cyst fluids, storing them. Probably some genetic markers will help, especially the KRAS, GNAS, and especially if the patient is young, probably we need to consider more aggressive follow-up, and we need to understand the cyst growth characteristics also. Probably that is also important on follow-up. It is nothing wrong, probably we can wait for 6 months or 1 year and understand the cyst growth characteristics and see whether some new worrisome features are developing and subject them for resection or surveillance.
So would you advocate simply going by the ultrasound characteristics of the cyst rather than sampling, which obviously can give you some variable results and also puts the patient at some risk of complications?
So as of now, we are still sampling, even in that size range of 2 to 3 centimeters. Yes, and we do often see these discrepant results. The CEA is still high, the glucose is not. The glucose is low, but still, all these discrepant results. That gives us confusion sometimes. Yeah.
Thanks.
Thank you.
Thank you, sir, for that.